No, we are on live, sir. We are good to go now.
Okay. Hello, good afternoon, doctors. Welcome to this experience sharing program on managing PPH, case studies from labor room. This program, doctors, is brought to you by Hetero Healthcare, an innovative pharmaceutical company. Hetero Healthcare, the journey began in 1993. We have 25 plus years of excellence and 36 state-of-art manufacturing facilities, 300 plus products in portfolio and presence in 126 plus countries. Hetero Healthcare has 21,000 employees globally and is the largest closely held pharmaceutical company in India. Hetero Healthcare is among the largest manufacturers of ARV, API, and FDFs in the world and has Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. Hetero Healthcare is a 360-degree solution provider striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. Hetero Healthcare pioneers in quality and innovation and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. During COVID-19 pandemic era, Hetero Healthcare, the pioneers in antiviral, offered oseltamivir, favipiravir and remdesivir to the patient, because of which in August 2020, Hetero Healthcare received an award of Pharma Excellence for COVID drugs from Express Pharma. Today's program, Experience Sharing Program Managing PPH, we have got Honorable Speaker Dr. Bharti Singh with us. Welcome, Madam. Welcome to this webinar.
Thank
Dr.
you, sir.
Bharti Singh is MBBS DGO MD Gold Medalist from Patna Medical College and Hospital, the Scrutable Madam. Ex-resident of PMCH, Patna, practicing in Deoghar since 2018 till date in Tridev Hospital, Deoghar. Over to you, Madam.
Thank you. Postpartum hemorrhage, a daunting event. PPH is a loss of at least 500 ml blood following vaginal delivery and 1000 ml following cesarean section. PPH is common and can occur even in women who are not at risk. PPH is the leading cause of maternal mortality in low-income countries and the primary cause of nearly 1/4 of all maternal deaths globally. PPH, it's unfortunate yet common. Maternal mortality, it is the leading cause of maternal mortality, accounting for about 35% of all maternal deaths. Maternal mortality ratio in developing countries are 240 per 1 lakh live birth compared to 16 in developed countries. Global PPH incidence. 14 million women suffer from PPH. Incidence of PPH is reported as 2 to 4% after vaginal delivery and 6% after cesarean section. PPH incidence in India. 38% of maternal deaths are due to PPH. 25.7% of global deaths take place in India and 2/3 of these attribute to PPH. India has an unexpectedly high maternal death rate of 540 per 1,000 live births. Etiology of PPH. PPH is basically due to there are 4 T's responsible for PPH. First is tone. If there is any problem with failure in uterine tone, if uterus do not contract properly following delivery, then it leads to continuous bleeding, that is uterine atony. Second one is thrombin. If there is any kind of coagulopathy, it will lead to failure in clotting, which will lead to PPH. Third is trauma. Any kind of uterine trauma, cervical trauma, vaginal trauma, uterine inversion, lacerations will lead to PPH. Tissue. If the placenta is not removed completely, if any bits of placenta will be retained, or in case of abnormal placenta, if any of the lobe of the placenta will be retained, it will lead to PPH. Clinical findings in PPH. There will be abdominal tenderness. There will be circulatory collapse due to blood loss, increasing abdominal girth, loss of uterine contractions, uterine atony will be there, maternal tachycardia, vaginal bleeding. Clinical findings in PPH. Due to blood loss, patient land up in shock. That can be mild, that can be compensated, mild, moderate, or severe, depending upon the amount of blood loss. If the blood loss is 10 to 15%, means 500 to 1000 ml, that will be compensated. In this, there will be no change in blood pressure, and the symptoms and signs will be only palpitation, dizziness, and tachycardia. In mild, there will be 15 to 25% of blood loss, 1000 to 1500 ml, and there will be slight fall in systolic blood pressure. That will be 80 to 100 millimeter of mercury, and symptoms will be weakness, sweating, tachycardia. Moderate shock, there will be 25 to 35% of blood loss, 1500 to 2000 ml, and there will be marked fall in systolic blood pressure, 70 to 80 millimeter of mercury, and symptoms will be restlessness, pallor, oliguria. Severe, there will be 35 to 45% of blood loss. That means 2000 to almost 3000 ml of blood loss. And there will be profound fall in systolic blood pressure, 50 to 70 millimeter of mercury. And symptoms will be collapse, air hunger, and urea. Approach towards postpartum hemorrhage. First, clinically, we will have to find out what is the cause of PPH, the 4T, whether it is due to uterine atony or due to defect in coagulation factor or trauma or retained tissue. The first diagnosis we have to make, we have to find out the 4T, and when we reach out to a diagnosis, then one after one, if it will be due to uterine atony, poor uterine tone, then the clinical findings will be abdominal palpation, uterus feels relaxed, boggy, and soft. Uterine fundus may be felt above the umbilicus if uterine cavity is filled with blood and clots. Investigations, full blood count, if patient is not responsive to fluid and blood replacement. Investigations, we have to do basic investigations, full blood count, coagulation profile, urea and electrolyte, abdominal ultrasound to exclude uterine rupture or intraperitoneal bleeding. Management, uterotonic agents, oxytocin, prostaglandin, ergot alkaloids, uterine balloon tamponade. Then if it will be due to trauma or tear, then clinical finding will be from area of trauma, there will be bleeding. It may be uterine rupture or extension of uterine angles, tears during cesarean section, external genital causes, cervical tear. Investigation, basic lab investigations will be same, CBC, coagulation profile, and other investigation, if it is due to cesarean section, then we will do exploratory laparotomy and see the site of bleeding. Ultrasound will help to identify uterine rupture. Management, repair of identified site of trauma, suturing the blood vessels. Pelvic arterial embolization may be required in case of broad ligament or supralevator hematoma. Retained tissue, the clinical findings will be retained placenta and membranes that will be identified during bimanual examination. Investigation, examination under anesthesia. We can also do ultrasound to pick out retained tissue. Management is manual removal of placenta or retained products of conception under regional or general anesthesia. Coagulopathy, the clinical finding will be continuous bleeding despite contracted uterus. And this is a diagnosis made of exclusion. If there will be no tear, trauma, atony, and retained tissue, then there will be chance of coagulopathy. Investigation, same basic investigation and coagulation profile should be done. Management, immediate replacement of blood and coagulation factors and platelets. surgical only with trauma or atonic hemorrhage, unresponsive to medical. Attempts should be made to identify the cause in women who are bleeding in parallel with resuscitation. Resuscitative measures should be go parallelly. Next slide. Hello.
Hello, doctor. I think Dr. Khandeparkar sir has left. Maybe he'll join back soon.
Okay.
I'm sorry, madam. Suddenly I was logged off.
Okay.
You can see, madam.
Yes, sir. Rationale for the development of carbetocin in new heat stable formulation. Carbetocin is available in a room temperature stable formulation and convenient vial presentation. Oxytocin and ergot alkaloids should be kept in a refrigerator to avoid degradation. Heat stable formulation of oxytocin is currently not available. Previous formulation of carbetocin should be stored between 2 and 8 degrees centigrade. Resource poor countries do not always have cold chain transport and storage capability. There is need for refrigeration. Carbetocin is stable at room temperature, has shelf life of 24 months at 30° and 75% humidity. Avoid needs for cold chain storage and logistic. Is provided in a vial. Use of uterotonic agent. Time of administration. At the crowning of baby's head. At the delivery of anterior shoulder. At the end of second stage of labor. Following the delivery of placenta. Prophylactic use, prevention of PPH, active management of third stage of labor. Therapeutic use, management of PPH. Molecules, molecules oxytocin, carbetocin, ergometrin, symptometrin, misoprostol. Carbetocin, a next generation drug for PPH management. Carbetocin was created by making several modifications to the oxytocin structure that prolongs the half-life, reduces enzymatic degradation. This is synthetic long-acting analog of oxytocin. Therapeutic indication is prevention of PPS due to uterine atony. Administration that is 1 vial contains 100 microgram of carbetocin in 1 ml solution for injection. Clinical evidence. Basic difference between oxytocin and carbetocin. Brief description. Oxytocin is synthetic cyclic peptide form of naturally occurring posterior pituitary hormone. Binds to oxytocin receptors in the uterine myometrium, stimulating contraction of the uterine smooth muscle by increasing the sodium permeability of uterine myofibrils. Carbetocin is long-acting synthetic analog of oxytocin with agonist properties. Bind to oxytocin receptors in the uterine smooth muscle, resulting in rhythmic contraction, increased frequency of existing contractions, and increased uterine tone. Pharmacokinetics. Oxytocin can be administered IV, almost immediate action with peak concentration after 30 minutes. IM, slower onset of action taking 3 to 7 minutes, but produces a long-lasting clinical effect of up to 60 minutes. Half-life is 1 to 6 minutes. Carbetocin, IV, sustained uterine contraction within 2 minutes, lasting for about 6 minutes, and followed by rhythmic contraction for 60 minutes. IM, sustained uterine contraction lasting for about 11 minutes and rhythmic contraction for 120 minutes. Half-life 40 minutes. Storage and transport requires protection from light and storage at 2 to 8 degrees continuously to preserve its activity. Storage condition up to 30 degrees centigrade. Clinical indication, oxytocin. Induction of labor, carbetocin, no. Augmentation of labor, oxytocin, yes. Carbetocin, no. Prevention of PPH, both can be used. Treatment of PPH, oxytocin, carbetocin cannot be used. Carbetocin, non-inferior to oxytocin. WHO champion trial. Champion Carbetocin hemorrhage prevention, the largest clinical trial in the prevention of PPH. Trial conducted by WHO Department of Reproductive Health and Research. A study design, non-inferiority, double-blind randomized trial, objective to compare the effectiveness and safety of investigational heat-stable carbetocin to oxytocin in the prevention of PPH after vaginal birth. Patient enrolled 30,000 women across 10 countries, including India. Primary outcome, the proportion of women with blood loss of at least 500 ml or the use of additional uterotonic agents. The proportion of women with blood loss of at least 1 liter. Parameter, blood loss of more than 500 ml or the use of additional uterotonic. Carbetocin efficacy 14.5%, oxytocin 14.4%. Non-inferiority established. Blood loss more than 1 liter, carbetocin 1.51%, oxytocin 1.45%. At least one and unanticipated AE. Safety 4.9% for conclusion. The carbetocin was non-inferior to oxytocin for the prevention of blood loss of at least 500 ml or the use of additional uterotonic agents. Cochrane review. Carbetocin for preventing PPH. In this Cochrane review, data from 11 studies involving 635 women were included. The author concluded that for women who undergo a cesarean section, carbetocin resulted in a statistically significant reduction in the need for therapeutic uterotonic compared to oxytocin. Also, carbetocin is associated with less blood loss compared to symptometrin in the prevention of PPH for women who have vaginal delivery and associated with significantly fewer adverse effects. Guideline recommendations. Guidelines recognize the benefits of carbetocin for preventing uterine atony. Different guidelines: Society of Obs and Gynecology of Canada, Danish Society of Obs and Gynae, Ministry of Health of the Russian Federation, Chinese Society of Obs and Gynae, expert group of Polish Gynecological, Mexican, Philippine, Queensland Maternity and Neonatal. Recommending body WHO 2018 guideline for PPH, carbetocin, Canada. Different guidelines recommend carbetocin for prevention of PPH. My experience with carbetocin. Case 1, age 32 years, gravida para, gravida 2, para 1, gestational age 38 weeks, 5 days. Indication for LSCS, previous cesarean with non-progress of labor. Risk factor, mild anemia, 9.6 gram per deciliter. Clinical experience, in this patient, carbetocin was administered as a single IV dose immediately after delivery of the baby during cesarean section. The uterus contracted well within a few minutes, and good uterine tone was maintained throughout the surgery and post-operative period. Estimated blood loss was around 400 to 450 ml, which was well within acceptable limits. No additional uterotonics were required. The post-operative recovery was smooth with no excessive bleeding observed. In my experience, carbetocin provided sustained uterine contraction and reduced the risk of postpartum hemorrhage, especially in this moderately high-risk cesarean case. Case 2, normal vaginal delivery. Patient details, age 26 years, gravida 1, para 0, gestational age 39 weeks, mode of delivery, full-term normal vaginal delivery, risk factor, prolonged second stage of labor, clinical experience. After delivery of the placenta, single dose of carbetocin was administered. The uterus remained firm with effective contraction and blood loss was minimal, approximately 250 ml. The patient remained hemodynamically stable and no additional uterotonic support was required. There was no significant adverse effects noted. Compared to routine oxytocin infusion, carbetocin offered the advantage of single dose administration with reliable uterine tone, making postpartum management simpler and more effective. Overall clinical impression. Based on my clinical experience in both cesarean and normal delivery cases, carbetocin is a dependable uterotonic with long-lasting action. It simplifies postpartum management, reduces the need for repeat dosing, and helps in effective prevention of postpartum hemorrhage, particularly in patients with risk factors for uterine atony.
Madam, thank you very much, for sharing your experience. It is very
Welcome.
interesting to see that, both the cases, cesarean section as well as normal delivery, prophylactic use of the drug immediately controlled the bleeding, and less than 250 ml was lost. Another case, there was the patient was anemia. I suppose anemia is a major risk factor in our country. I mean, we have seen patients as less as 5 or 6 hemoglobin. I'm sure, madam, you must have experience like that.
Yes, sir. Yes, sir.
And what is the benefit of using carbetocin as a first line drug?
Longer duration of action and
Longer
less blood
duration.
loss.
Okay.
Longer duration of action, less blood loss, and less requirement of other uterotonics.
Uterotonics, correct. So if you have to use it as well first line so that you control the PPH very fast. Because this is used for prophylaxis of PPH, actually not for treatment. So use the drug in prophylaxis, maybe you will not require treatment. Something like that. What is the patient profile where doctors can anticipate PPH?
And patient with anemia, multigravida, pregnancy-induced hypertension, multiple pregnancy, coagulopathy.
Okay. Even I suppose fibroids can also precipitate PPH, I suppose, no? Between pregnancy, if anything that can increase the uterine size. Can you use carbetocin in RH negative mothers? Any experience?
Yes, we can use.
Okay, since how long you have been using carbetocin, madam?
I have been using for 2 to 3 years.
2 to 3 years. And generally, which form you use? IV or IM?
IM. I
IM.
use IM. Till now I have not used in IV. I have used IM.
Okay, okay. That's the advantage of the drug. Single ampule, single injection, IV, IM is always good. Now, this is another question. If oxytocin is used for labor induction, can a doctor use carbetocin for prevention of PPH?
Yes.
They can, because most of us use oxytocin for labor induction. Oxytocin is our textbook brand. So we use oxytocin for induction. So you can safely use carbetocin. No worry about it.
Sir, one
And
question. We can't use carbetocin for treatment of PPH.
yes. It's only recommended for prophylaxis.
Why not for treatment of PPH?
I mean, there are no studies, which is why they recommend for prophylaxis.
If we use for treatment, then is there any problem?
We don't know because it's not, there are no studies of use of carbetocin in treatment of PPH. The treatment, the studies are all in prophylaxis. Even WHO, when they conducted that champion trial, it was a prophylaxis of PPH. That's what they recommend. And you generally use IM, but if you have to use IV, which patients would you use IV route?
Which patients?
IV route. If you have to use IV route, or you are happy with IM route.
I am happy with IM route.
That's wonderful, na? Rather than giving one more IV. And what is your experience about adverse effects of carbetocin?
Till
Any
date,
side effects you have seen?
I have not experienced any.
That's side effects.
Mm.
That's very good, no? And suppose the patient does not respond with carbetocin, what other uterotonics you will use?
Then I will use ergot alkaloids.
Ergot, methergine type, ergometrin.
Mm.
And should it be kept as a reserve drug or the first line?
First line.
First line, and which you have been using in your hospitals. So to conclude, what is your take-home message for the audience?
Carbetocin should be used for prophylactic management of PPH.
And the drug acts without any major side effects. It's tolerated well.
Till date, I have not experienced any major
Yes,
side effects.
yes. Wonderful, madam. Thank you so. Yeah.
One question: can carbetocin be used in patient of DIC?
In DIC,
DIC.
I will check and I will let you know, madam. Whether there is any data.
Once I have faced a patient of DIC. In that I
Disseminated intravascular coagulation. No?
after cesarean delivery, patient complicated and finally she landed up in DIC and she
Oh,
admitted in ICU in a ventilator.
baap re. In our science, expect the unexpected. Any patient can land in any
So
problem.
that patient was in obstructed labor and sepsis, and finally she landed. She came to me after delivery, post delivery.
Oh, yeah, referral.
Referral with PPH. Mm.
That is the worst case. A referral means you do not know the past history, you do not know patient history, and you have to act immediately. That's the worst scenario.
Referral that came as referral with PPH.
Baap re.
Mm.
A referral means we do not have any data, no, basically. Thanks, madam. Thanks for taking time and sharing your experience. Your
Thank you.
experience, I'm sure, will have benefited the doctors who have attended. Thank you, doctors who took time and attended. Thanks, sales and marketing team of Hitro, and thanks, IT team for coordination. Thank you so much. And madam, you can log off. Wish you a very pleasant evening. Thank you very
Okay.
much. Thanks, Bhuvan. Thanks, Tanvi. We can sign off. You can sign off, madam. Thank you.
Thank you, sir.
Thank you.